Welcome back to the PA is in, the podcast by PAs for PAs. Today on the show, we have Dave Mittman. Dave has been a leader in the PA profession for over 40 years. He's going to share with us his thoughts on optimal team practice, where the future of the profession is taking us, and what practicing as a PA looks like in a post-COVID world. I'm so excited to share this conversation with you. Without further ado, here he is, Dave Mittman. We interrupt this broadcast with a very important announcement. You are not making enough money. Your practice and your physician do not understand the value you are adding to their patients, and therefore, you aren't earning what you're worth. If in the past your requests for a raise have been met with one single word, no. If you're working more hours than ever and seeing more patients, but you're not making any more money and you're feeling pissed about it. If you feel like you've hit the ceiling of your income band, this guide is for you. I've compiled the 5 most costly and most common mistakes that PAs make when asking for a raise, and I've told you how to avoid them and what to do instead. Download your free guide at tracybingaman.com/mistakes. Awesome. So Dave, welcome to the show. I would love it if you could tell us a little bit about yourself.
Hi, everybody. I'm really glad to be here. Let's see. I have been a PA leader for my entire life. Seriously, I graduated PA school at 23, having already been vice president of my class, and then 2 years later, or a year later, I was on the board of the New York State Society of PAs, and 2 years after that, president of the New York State Society of PAs, and then probably 3 or 4 years after that, on the AAPA board in the early 80s, and I worked for 8.5 years in primary care. I was the first PA in the Air Force Reserves, which was really cool, really fun. I was a former medic before that. What else did I do? I worked for our official publication called Physician Assistant Journal back in the 80s, and started our own publication later on called Clinician Reviews, or my own, with 2 partners. So I became an entrepreneur. And we built a really successful publishing company. We sold it. And since then, I've been really working for the profession. I started a web community called Clinician One, but really, and that we sold also, and that's kind of gone to sleep now. But generally have been a PA entrepreneur leader. I'm teaching now at Lynchburg I'm part of the faculty or adjunct faculty at the doctoral program, and I'm teaching advocacy. So for those of you that want to hear more about the way I think of things, I'm teaching advocacy at Lynchburg. What else am I doing? I'm still very involved, and I think it's just in my blood. I've asked myself why sometimes, and I can't figure out why, but I enjoy it, I love it, and I really love the profession. And most of the people in it, I call family.
Awesome. Well, I'm really excited to share the wisdom and the leadership that you have experienced as you've seen this profession change over the nearly 5 decades that you have been a part of it. So today we're going to unpack 3 things. So we're going to talk about COVID and the changes that COVID has had on the future of healthcare and what that looks like for PAs in the future. We're going to talk about the future of the PA profession and like the branding and sort of image that we're presenting to the world. And then we're going to touch on OTP and your thoughts on the title change. So going from physician assistant to a physician associate. So we're going to start with COVID and how COVID changed the future of healthcare. I feel like we have started using this like post-COVID world, in the post-COVID, post-pandemic. So let's talk about COVID, the impact that it had, and what that means for the future of healthcare and the PA profession.
Well, thank you. Like everything else in life, I think we all tend to look at things on how they affected us. I mean, obviously, there are public health issues. There are things like the general public lost faith in institutions like the CDC and the government and looked at healthcare professionals in general as people that I think now still that they have less trust in. But like I was beginning to say, I believe, especially for us talking today, that we look at everything a little bit towards with an eye towards how it affected the PA profession, or how did it affect medicine really, but the PA profession more. And so I think the first thing it did, without a doubt, was it took telemedicine from really being something that psychiatrists used for the most part. You wouldn't find most internal medicine practices or, certainly surgeons, God no. Even talking to someone over Zoom or even on the phone. And now it's an accepted part of medical practice. Not only that, you look on TV and you can get everything from stuff to grow your hair to erectile dysfunction to anxiety meds and depression meds on telemedicine over just over the web with a little conversation with a medical professional, whatever that is. So yeah, it changed healthcare and people got used to it. It's not an aberration anymore. It's going to be the future. Now, how much of it's going to be the future? I think a considerable amount, actually. But it really did change healthcare. So that's number one. I think people have much less of a commitment to an individual practitioner. People, COVID hit, and they ran to there you go, best intentions. They ran to their GP, their internist, their whomever, and they said, "Wow, we're gonna see you, and we're gonna learn all about COVID, and we're gonna make sure everything gets better." And you know what happened? It didn't. And the offices were closed. Um, People had no access to health care. So what did they do? They learned that urgent care was still open and the emergency room was still open. And they were scared to death to go to both places. So now we loop back around to telemedicine. But their regular internist was scared to death of seeing patients. So they closed their office. And I know mine did. I know most of the offices closed in where I live. I live in Florida now. Where I live, most of the offices closed. So people realized that the true and trusted places they went to might not ever be there. So they found other ways to access healthcare. And I think that commitment to an individual practitioner really ended in the way that it used to be. Oh, I love Dr. Jones. I've been seeing him for 40 years. That kind of stuff's over. It's really over. So it ended that. I also think that people became more worried about healthcare in general and anything respiratory, anything that looked like COVID, and still are, by the way, that has not ended. Um, and now with RSV and we don't know what the winter will bring between flu and RSV and COVID, and something else may erupt. At the end of the day, again, people are very suspicious. A lot of people over 65 did not take the fourth booster. I really think that people are now more worried about their health than they've ever been, more concerned about it, and yet unwilling to trust the people in charge. And that's not happened for a long time in America. It really hasn't. So COVID did that to us. And then we have more people working from home. So we're going to see the types of illnesses that we always saw in an office setting that spread fast, like the flu. Okay, we're going to see that. But are we going to see more childhood illnesses spreading to mom and dad because mom and dad are working at home now and the kids are the ones going out to work? They're going out to school. So are we going to see those illnesses start to creep back into the adult population? Or are we going to catch the flu from the kids, is my point. I don't think we're going to get mumps and measles and the things that we've been vaccinated against, but I think there are things kids can bring home. And we're going to get those, and we're going to have to be more aware of those kind of illnesses. And now let's bring it to PAs. Um, I think part of your people who are watching this don't know that the governors in 10 states issued executive orders. And those executive orders came out very much at the beginning when COVID hit. And what they did was they made us, quote, independent, unquote. So I'm using the I word here. I know we don't use it much, but it really did, because it wasn't really OTP. And we'll talk about OTP later, because OTP is a package. It's what you find under the Christmas tree or your menorah or whatever. It's a whole bunch of presents. It's not, this was one present. And what the governor said was, listen, we know you're practicing with barriers and archaic regulations, or else they wouldn't have done it. So they knew that. And they said, okay, we're going to take those archaic regulations and we're going to throw them away. You don't have to worry about those anymore. You don't have to worry about supervision. You don't need collaboration. You don't need supervision. Go out and make people better. So if a PA was assigned from the emergency room to the ICU, you don't have to change your supervising physician in the state capitol and find a supervisor in the ICU. You don't have to, if you were in family practice and now you're in urgent care, or you were in urgent care and now you're in the ER, or wherever you were shifted, you didn't have to worry about a thing barrier-wise, legislative-wise, all this legal stuff that they always put in front of us, they took away. And so take a state like New York. I think there's still 4 or 5 states where the executive orders are still in effect. But let's look at New York, because it's our largest state. And if we want to say something about, I've heard over the years, and especially when it just passed OTP as a policy from the AAPA, PAs can't do that, or they don't want to do that. And again, people didn't understand what it was, and we'll go back to that. But if we take New York and its executive order, there are 30,000 PAs in New York. 30,000. There aren't 30,000 physicians in many countries. And then we made them overnight all independent. Now, they didn't all of a sudden all run out and open up offices. They stayed where they were, but they didn't have all this stuff to wear and the tether to someone else and all this regulatory burden. It was all taken away. So they could practice like everyone else practices, just on their own license. And it worked. And don't forget also, I'm sorry, it's not 30,000, it's 19,000 PAs and 30 PA programs. Sorry, take that one back. So there's 30 PA programs, graduating students, and now here we are 33 months later, and 24 and whatever, it's probably about 33, 34 months later, after the first executive order was issued, and they have to be renewed monthly, by the way. And New York still is independent. Still, now we know we can do this. And that, to me, if you have to get a silver lining from something that's horrible like COVID, that's the silver lining. To have 19 or 20,000 PAs practicing for 33 months, and the educators were saying, well, we can't graduate students into something where they don't have legalized supervision, where they must be supervised. Well, you know what? We did, we can, we will. And that, I think, was the present that, unfortunately, COVID gave us. And some of the nurse practitioner states, by the way, and some optometrists and other professions got modernized. Some of their restrictive elements of their legislation were taken away also. So it wasn't just us, but I think the largest impact had really to do with PAs and NPs.
And it sounds like COVID forced the government, which is not known for its ability to move quickly or make decisions in an expedited fashion, to address a need, right? So something happened and there was this massive need, and they saw a part of the workforce that could help to meet that need. And also, it sounds like that's what we were trained to do. It's really what we've been doing in practice despite these barriers and regulations and limitations. It's what PAs were doing practically after waiting for paperwork for the last 40 years, right? So we were already serving this need. It just made it so we were more fluid and we could adapt quicker to meet the needs of the patient population based on what was happening.
Right. That's it. And we didn't have to deal with the administrative burden that was placed upon us almost uniquely. You know, again, NPs also in some states, but there's 25 states where NPs don't have that burden anymore. And we do.
So talk to me about the future of the PA profession, kind of in light of these executive orders, in light of this little experiment, if we're going to call it that, where we said, hey, what happens if? And now we don't have to say what would happen if we did. We've already done it. So we already did almost 3 years without these barriers. What does that say for the future of the profession? And how can we use that? How can we leverage that evidence to say, hey, all of the other states that have these limitations, these barriers, these things that are prohibiting PAs from functioning in the way that they were designed and trained to function, how can we use that for good for the profession long term?
Well, certainly that leads into, and we'll do that later, OTP, and whatever OTP really means, and we'll discuss that. But I think the future is bright, but there are things that we're going to have to do because we've been given the ability to start doing them. See, what we don't realize, and again, this goes along with OTP, and really the future has to do with forming a real profession now. So when we were in school, nobody told us that professions self-discipline, self-regulate. Okay, they make their own standards. Those are what professions do. Architects do that, engineers do that, physicians do that, nurses do that, physical therapists do that. Whoever's a licensed profession gets to do all that stuff. We don't. We have another profession overseeing us, even on the medical board. So all of that has to be looked at in the future if we're going to be a real profession. A real profession self-regulates. So that, again, it's all going to fall under OTP. But let's look at a couple of things that won't fall under OTP. Credentialing. So if your state, we have 3 states now, and then again, a couple of states under executive orders, we have 3 states with OTP, with full practice, where PAs do not need a supervising physician. It's going to now be incumbent upon us to put together a system where we credential each other, where the profession credentials us, where insurance companies, where hospitals, where consumers say, okay, you are credentialed as a PA in psychiatry. You just didn't say, I'm a PA in psychiatry yesterday, or ENT, or women's health, or, let's name the, whatever we're in, or family practice. Although we're closest by schooling to a general or family practitioner, at the end of the day, the insurance company is not going to pay you without showing them what you've done. And I think we're going to, like all other professions have done, we're going to have to learn how to get credentialed and how to show our worth. And it may be what procedures we could do. And again, that's going to be done both, and we're going to talk about this later, but both for insurance companies and hospital credentialing committees and oversight things, and maybe the government in certain areas like Medicare, will want you to get credentialed. but it'll also be done at the practice level. When you take a new job, you're going to bring that stuff with you. You're going to bring that information with you, saying, I can prove, just like physicians do, just like physical therapists do, just like pharmacists do, I can prove my competency in these areas now. It's not just that, and we're going to have to figure out how to do that. And, personally, I don't want to see 70 more tests. I think there's probably a better way to do it. I don't know what they are. I have my ideas, and that would take a half hour to discuss. Maybe we can do that another time. But for right now, no credentialing is going to be an area. What degree do we have is going to be an area we're going to have to look at, not 30 years from now, but 5 years from now. Because there are going to be PA programs 5 years from now with entry level doctorates where they're going to add 5 or 6 months, and those 5 or 6 months will consist of leadership and administration and how to run a clinic and how to do other things, and maybe add on some more clinical. But now we have the add-on doctorate, and I'm not saying any of these will be terminal, where we're gonna decide that every PA has to have a doctorate. It won't be like that. It will be like the master's degree. It'll slowly just happen. And the master's degree was argued for 20 years, and it never got solved. What happened was all the programs just changed to it.
Started doing
So
it.
it was
Yeah.
solved on its own. And it's the same thing going to happen now. And we have to realize that all other professions, all who do what we do, okay, so diagnose, treat, and forget about prescribe, just diagnose and treat. Basically, almost all of them, I'd say all of them, but I'm thinking of social workers who do diagnose and treat in a way, but other than social workers, have doctorates. So, we have the PT, the OT, the NP, the audiologist. I mean, forget about physicians, the chiropractors, a zillion different professions. I think there's 12 with doctorates now. And we certainly do what they do. Our time spent in school in graduate hours is same or more than the PT, then the OT, then the audiologist. So I think the hours spent already qualify us. So if we added in 3 or 4 months and we gave our students advocacy lectures, or we gave our students lectures in how to be, how to be a significant piece in a hospital system, how to get heard, how to join a committee, what a committee is about, things that were never, what is a profession about? What do you owe your profession? What does your profession owe you? Things like that were never discussed, I know, in PA school for most of us, because you had to cram in all that science, and I understand that, all that medicine. And, and that's important. There's no doubt. But we're finding out we need more. We can't graduate people who just know medicine, but don't know anything about the political system, or don't know how to advocate for themselves, or don't know how to sit on a hospital board or a credentials committee or a whatever, formulary committee or something, or don't even know that they should have business cards or their name on the door of the practice. And we have students that don't know that. So I think those are the things. And I really do believe, it's funny, this is the last part of where the future goes for now, because I've given us enough to chew on. But we had a bunch of PA leaders do some Zoom calls for a while, just discussing the profession, not settling anything, not even trying to settle anything. And we agreed that the number one problem in our profession was apathy. And I think if you speak to most PA leaders, they'll say the same thing. And so, how do we get preceptors, people who teach, young PAs, or not young by age, but new PAs who've just graduated, all enrolled in the fact that they really have to be not only involved, but spokespeople for our profession and meet with legislators and do all those things. And that's we're going to start graduating. Today, we graduate 10,000 PA students a year. That's going to go pretty soon to 11,000. We're getting new programs every day, it seems like. And when it's 11,000 in 5 years, that's 55,000 more PAs out there. And that's probably a third of the number that we have out there now. It's about 170, 175. So it's certainly a lot of people. If we could just forget about everyone else, those 55,000, and teach them to really be ambassadors and go out and make a difference, not in just a medical way, but in an advocacy way, that apathy would start to end. Join your state organization, support whatever you can, even if it's just with money. It would be astounding. So that's going to be something we have to look at. We just have to look at. Donate to the PAC in your state and the AAPA's PAC. And if you don't like what the leaders are doing, let them know. It's not, oh, I don't like them, I'm not joining. No, let them know. And because we have to push ourselves forward. We have to. And so that's my last future thing that we must do.
Yeah. And when you're saying that, it really sounds to me like we're saying what we need is a movement amongst practicing PAs and newly graduating PAs to understand that being a good steward of this profession, moving us forward and getting us to some of these things where we have been close to, but not quite doing what these other professions who are self-regulating, who are doing some of these things are doing, is your responsibility. And you are responsible for being a steward of the profession. And we have been given this gift, and we are in this time where there's going to be a ton of new PAs joining us. So starting to talk about it with your colleagues, starting to talk about it with the students that you're precepting, starting to share about it with people in your community and in your life, that makes an impact. And if everyone makes a small change and joins their state organization and donates and starts to speak on this and become aware of what the issues are, that's going to create a critical mass of PAs who are ready to create change and who really want to be stewards to a profession that they love.
Agree.
Yeah, I think that's a huge deal. So let's talk a little bit about branding. I think during PA week, this is always very obvious to people. People are posting about PAs, but what is the AAPA doing? What are people doing to sort of brand the profession going forward? What did we do maybe not so well before, and what can we do better in the future?
Okay, well, I guess the biggest part of branding is going to be title change. And we're still a little, I guess there's some controversy not around the title anymore. It is physician associate, but whether one should call themselves that in front of patients or not. So let's say don't do that yet. Although I believe, I have my beliefs that if we went to the medical board and said, listen, physicians, that's the title of most quote unquote doctors we know, and I have never heard a doctor call themselves a physician ever. So let's not get into titles right now. Associate is not physician, and then we have 5 other professions that call themselves physicians that are not physicians. So chiropractic physicians and podiatric physicians and optometric physicians and naturopathic physicians and all these people who are not physicians. MDs and DOs are physicians. Everyone else are not. But they're calling themselves that, and the medical board isn't doing anything. So I'm not sure that us going to the medical board and saying, hey, would you not, be angry at us if we were associates, would be that big a thing. And again, this is why we need to modernize our profession, because we shouldn't have to be going to anyone to say we want to change our title. as a full-fledged real profession, we can just change our title if legislatively, that's a different thing. But we shouldn't have to worry about the medical board coming down on us because we'd have our own board. And at the end of the day, anyway, we do have a brandable title that now we can make into whatever we say it is. A physician associate can be a partner, a not partner, a person close to. An associate is someone who works with someone else on a professional level, basically. That's what it is to me. If someone says, I'm going to be busy, but you can see my associate, it yes, okay, who are they? What are their credentials? What do they do? But it's not someone's assistant who really, let's not go into that again, but an assistant did the prep work so the person who did the job could do the job better. We don't do that. We never did that. So we have a brandable title now. And then we have what the AAPA is trying to do. And it's a really branding campaign of PAs go beyond. And I think you're going to be seeing much more innovative and things on TV, things on the radio. You're going to hear PAs go beyond much more than we've ever seen before. And yes, there was some zenith a little bit around PA week, and now it's gone down, but I think we're going to see it. From what I hear, we are going to see it. So I guess, how do we brand physician associate is the thing. Well, the programs slowly, and I understand that there are legal battles and there's deans that you have to convince, but the programs have to change because students shouldn't be graduating anymore with assistant on their degree that they're going to hang up in their office for the rest of their life. Because we've made this decision a year and a half ago now. So it's time. And our state organization, same thing. And they feel that it interferes with OTP, but to change the name of your state organization is not a legislative thing. All you have to do is, like the AAPA changed its name, and it's now the American Academy of Physician Associates. You can look on the website, and it showed that they were serious about this. And I think if a state's serious about it, the state's going to do the same thing. And I think we should start using it amongst ourselves, or if we go to a CME, or if we go to our state organization's meeting, or an EPA meeting, or if we're at a regular conference, we should say, "Hi, I'm Dave. Mittman. I'm a physician associate in Florida, and here's what I'm feeling or doing or saying or whatever." And again, in front of patients, that's going to be a personal decision. In some states, you can get in trouble, and I don't want anyone getting in trouble. So that's that. But we really need to realize that the profession made a real policy, again, a modernization change, a real difference in the way we looked at ourselves. And there are still people who are unwilling to look at themselves as other than assistants. And maybe it's just a psychological thing, whatever, and it's going to take time, but we have to start doing it, and leadership has to start first. So that's really where I see our branding on a very short-term basis. Obviously, I have advocated for us going on like Medscape or MedPage and just going on the medical parts and start to engage as medical providers and going on, writing for the town newspaper or the penny saver as a medical provider, as a physician associate or a physician assistant, if you want, or just use PA if you're really scared of associate. I get that too, but the assistant part really hurt us, and that's going away. And I think that's going to do more for our branding than any other thing we've ever done. So I'm very excited about that.
Yeah, I think it's a good change. I think it was a long time coming, and I think that it can feel turbulent when this stuff is happening and you're like, I'm a PA, I've been a PA, I've called myself a physician assistant, And now I have to call myself something new. There's this shifting identity that comes with that professional title, but also unity in that and getting behind that and starting to use it and starting to share. I was just visiting my aunt and uncle and I said, "Hey, did you guys know that we're changing the name of, that we're changing?" And they said, "We didn't know, but we're glad." And they're not medical. They just know that this is what I do. And they said, "We never thought of you as an assistant," right? So this is good for the profession and just having those conversations so that people are aware things are changing. Here's why. What we do will remain the same. Like what you do day to day in practice is not going to change. It's just the letters that follow that A and PA that are going to be a little bit different going forward.
You made a great point, and I'd like the listeners, the watchers, the people on here to get this. The AMA and the state medical societies are saying that PAs and NPs, but PAs want to change their scope of practice. And that title change is part of that. First of all, we've never asked to change our scope of practice for years. I mean, we haven't asked. We're not saying we want to be able to do open heart surgery, or we want to be able to do optometry, or we want to be able to do things that physical therapists do. We're not saying that. We're really happy with what we can do, which in most states is what a physician can do, as long as you're competently trained and you can show competence and all that. So we're okay. There is no scope of practice problem here. And the AMA uses the term scope creep. And PAs are trying to scope creep up our scope. No, we're not. We're not. And our title has nothing to do with it. Our title was just lying to the public for years, saying we assisted someone when we didn't. And assisted means someone else is going to come in and finish the job. And the poor patient sat in a room, and I came in and I diagnosed and I treated them and I gave them a prescription and I said, "See me in 2 weeks if you're not better, and take care." And I gave them a hug and they left. And that's not an assistant. I'm sorry. We lied to everyone, and many times it backfired on us because legislators don't know that it was just a code word to us, because we didn't want to get in legislative battles, which we're now going to have to get into anyway.
Yeah, I think it's time. Yep, it's time. All right. Speaking of it's time, let's talk about OTP. So what is it? What isn't it? And how does it affect a practicing PA who's wondering, is this going to change what I do?
Okay. So OTP was passed and by the way, titles change was passed a year and a half ago by the House of Delegates, and it is policy of the AAPA. So it's not just some PAs want it, it is our policy. Okay. OTP, same thing. It was passed 5 years ago. And what it really should have been called, and what it really did, was it was a way to look at PAs and modernize our legislation. Okay, most of our legislation in almost every state was written in the late 60s to the mid 70s, the early 70s. So if you're talking about, let's say it was written in 72, you're talking about 50 years ago. And it hasn't really changed. Oh, yeah, now you don't have ratios. Oh, yeah, now we don't have chart reviews every 30 seconds. But what the real legislation, and some states had great legislation. New York had great legislation 30 years ago. But generally, it really didn't change a lot. And there wasn't one state where you didn't need supervision anymore. There wasn't one state that said, we're going to look at what you did and we're going to create residencies for you. I mean, our whole way of being was really not that different from what Eugene Stead envisioned at Duke. And so we knew it wasn't going to work in the future. Medicine used to be one physician, Marcus Welby kind of person, because usually it was a male. And then they hired a PA and they worked so well together that they stayed together for years. And both of them needed each other. Well, we're not there. We're never going back. It's never going to happen. We have, you know, what to call private equity investors now own 17 to 20% of all medical practices. Forget about physicians selling out to hospitals. I'm talking about private equity who are going to resell that practice in 5 years. Because they're gonna get their bump up on their money and they're gonna resell. Nobody and physicians, we 57% of physicians, it's around that number, are employees now. Okay, and they don't have the same passion for opening up private offices in areas that where people need them. It's not happening. And so to go by laws that were written for those people in those situations is folly. And what we kept hearing was a couple of things. A, our laws weren't working. If there were never ever nurse practitioners in the world, our laws weren't working. They just weren't working well. B, NPs kept changing and modernizing their laws first and getting full practice and realizing that they could go to places and do things that PAs couldn't, or telehealth, or the Minute clinics, or other places. Amazon right now has Amazon Health, who announced they're hiring NPs and physicians. They're not hiring PAs. Why? Because PAs, I mean, this is my guess, PAs need a supervising physician. It costs more money, and why? Why? Maybe they'll just have a medical director for everybody there, or every 20 people or something, but they don't want to deal, employers don't want to deal with this anymore. And physicians don't want to deal with it. They don't want to be responsible for another clinician. They don't want higher malpractice. They don't want to stay later. They don't want to review charts. They don't want to do any of this stuff that in the 70s wasn't a hassle, because it was two people and you knew how good each other were. And after a few years, I don't have to say more. So what happened? We at the House of Delegates said, okay, we're going to call our new modernization optimal team practice. And it has 4 parts, and I'll go through them really quickly, but I want people to understand them. So, part 1 was a commitment to team practice. Now, it wasn't a commitment to team practice with just physicians, it was a commitment with 3 PAs, or 3 PAs and 3 NPs, or 3 PAs and a physician, or 3 psych PAs and 2 social workers, or whatever that team was better, and we were saying it, was better than practicing alone. So part of it was to say we really believe in teams, but we don't believe that teams should be legislated, and we don't believe that there should be a leader of a team because they're an MD. There should be a leader of a team because they have experience and they know how to do this thing that the patient needs best. So if it's psych stuff, maybe it's a psychiatric social worker. If it's ortho, maybe it's a physical therapist for that team. Even though we're all family practice people, that's what the team should be. So we decided that's going to work. Number 2 was it was the recognition that we needed a PA board of medicine, or a PA medical board, or whatever we would call it. And you hear the term PA medicine, and it's not like PA medicine's different than MD medicine. It's more like osteopathic medicine. When you hear that term, no PAs jump up and down. They say, oh, I understand that. That's osteopaths doing medicine. Well, PA's doing medicine. And we need a board of PA medicine, basically, so we can have a group of people that know us, know what we do, know our training, have been through our training. Okay, the medical board in almost every state, nobody has to visit a PA program. No one has to study our curricula. No one has to have been through what we've been through. They go to med school, and many of them are put on the medical board by the medical society. So there's some politics involved. Of course, it's a political placement. And at the end of the day, they're not there to see us in our highest level of education and experience and clinical acumen. They see us as competition. They see us as you can't ever, I mean, I've heard this from physicians. You can't do what I do because you didn't do what I did. You didn't go to med school. And the only people who can do, I don't care if we pluck all these foreign grads from Egypt and Morocco, they went to med school, but you didn't. And it's like, but you have no idea what I did. How can you say that? And they're like, well, we can say it anyway because we know it in our hearts. And that's the evidence based medicine they use to make their decisions. So we need that PA medical board to represent us and to plan for us and to discipline us and to do all the things a board does for any profession. And every profession has it. Every other profession has it. We also said number 3 of the 4 parts of OTP was reimbursement from any insurance company and Medicare should go directly to the PA. Why? It wasn't about getting the PA rich. It was about 2 things. Number 1, we were invisible in the system. Because if you're getting billed under someone else's name, then Dr. Smith is the number 1 Medicare and Medicaid provider in this whole county. But you know what? Dr. Smith's at home, and Dr. Smith employs 2 PAs and 2 NPs who bill under Dr. Smith's name. And now, and so we were invisible. And even when we spoke to Medicare and we said to Medicare, how much care do PAs and NPs give? Really? They said, well, we're not sure. Because there's incident 2 and there's all this stuff. We don't know. So we have to get rid of incident 2. But it was about reimbursing us in our own name for what we did. And we would also get a printout, even from a regular insurance company, when they decided to reimburse us directly, and know what we did, know our acuity, know the types of patients we saw, and here's the big one for me, know our self-worth. You'd have a piece of paper to say, here's the kind of patients I'm seeing. They're just like everybody else. I want to raise, or I want this, or I want the professional dignity I'm entitled to, or whatever it is you want.
It's the data that we've been looking for to
Exactly. And not to be invisible in the system. And so that was number 3, reimbursement directly to the PA. And I think everyone watching will agree with those 3 things. They're not radical things. And number 4 in modernization was elimination of supervision and collaboration. Because one profession that doesn't understand the other profession, that doesn't hardly even want to do it anymore, and the only reason they're doing it in these health systems is because they're getting paid to do it, is there's no reason. We have never seen a study that said supervision worked, because by the time you've discussed the case, and by the time whatever, it's a week later, it's 5 days later, it's 3 days later. Even if it's 6 hours later, the patient's gone. If you want to do consults, fine. You don't need legislation for that. Okay? Physicians talk all the time. There's hallway consults. There's, in the parking lot consults.
Curbside, yep, curbside consults.
Curbside consults. Hey, hey, Sally, I have this patient with whatever, what do you use for that? We do that all the time. We've always done that. Why do we need legislation when no one else has legislation that says to do that? Because we're lesser trained? We're not. An optometrist doesn't do everything an ophthalmologist does. But they don't report to an ophthalmologist. A physical therapist doesn't do what an orthopedist does, or a podiatrist doesn't do what an orthopedist does, but they don't report to them. They don't supervise them. A podiatrist, I am sure, refers to an orthopedist 10 times a day because they can only see in most states up to the ankle. So if someone comes in and their shin's hurting or their knees hurting, or they think they may have hip pain that is also showing up in their ankle or something, they're going to refer. That's what we can do. Experienced PAs do this right out of school. There's a difference, yes, but there's a difference in every profession. So the pharmacist who graduates on day one, who doesn't have another profession supervising them, but has their own, may have their own profession supervising them or watching them. They don't mix chemotherapy drugs on the first day out of school. The nurse doesn't run the cardiac ICU the first day out of school. So what we did was we looked at those other professions and said, we're going to do it at the practice level. We are going to decide, us as professionals, and also the people who work with us, the credentialing committee, all those people we spoke about who are going to be credentialing us, the insurance company, the hospital, everyone is going to decide what we do, just like they do with physicians, just like they do with pharmacists, just like they do with nurses, just like they do with physical therapists. And it worked. And, let's go back to New York. 3 years, whatever it is, almost 3 years, of people who are not, sorry for the puppy, who are not, have not been supervised at legally. Now, again, you can have that done on a practice level basis. You can have anything done, but another PA can be your supervisor. An NP can be your supervisor. And I don't mean supervisor where they tell you what to do. It's your go-to person. It's the person where, hey, go to Dave. You just graduated. I know you can do a lot, but you're going to see a lot of things that you're just going to have questions about. Dave will help out, and that's what we're talking about. And that's when we say collaboration should go down to the practice level. It's not collaboration with physicians. It can be with a physician, but it's collaboration as the healthcare team collaborates at the practice. And we've done that, and we can do that. And we have 3 states. We have North Dakota and Wyoming and Utah, who all have OTP. It passed. And so they're doing that now, and they have no supervision, and they're fine. But and they do what they do. And in some states, by the way, we're passing, and we are looking to even pass legislation where you work with a physician or another PA who really supervises you after you graduate for, let's say, 2 years, and then that goes away
for a period of time.
Yep. Just a professional. You do what you do, and you carry that throughout your life. So that's OTP. And I wish we could ask questions, but I think people will get it. I hope people will get that explanation, and it's going to. And you know what? We're going to do this with NPs. I mean, because they're going through the same thing when they pass full practice in a state. So I think a lot of this, we're going to emulate what other professions have done. We're going to look at other professions. And yes, the little steps that have to be done just for PAs will be done just for PAs. We're not looking to be cowboys and cowgirls. We're just looking to not have these barriers that hold us back, to where we can't go to areas of need. I, as a PA now, cannot, I moved to Florida. I can't even volunteer to see poor kids to do camp physicals. I can't give shots at Costco after being a PA for years. I could have run an emergency room, really, in New York. And now I moved to Florida, and even if I was licensed, I'm not, but if I was, I couldn't give an injection without having a supervising physician. That's ridiculous.
It doesn't make sense. Yeah, it's not. Yeah, it doesn't make any sense.
It's a waste of manpower and woman power, and a waste of all our educations. And there's just no reason. There's no reason. No one else has to do this. And 50 years ago, it made a lot more sense. We were an experiment. We were 7 years old. We didn't know how good we'd be. We didn't know we'd do residencies and fellowships. And look, what they're learning in the programs today dwarfs what I learned.
Yeah, I think the landscape has changed, the education has changed, and it's time for the legal and logistical landscape to keep up with the changes that we've made. Well, Dave, this has been great. I have been sitting here taking notes because I feel like I had a vague idea of what OTP was before we got on, but I really now get it. I feel like I have my hands around what it is and what it means for the practice. So, thank you so much for taking the time to share your knowledge with us. We really, really appreciate it.
You're welcome anytime. Whenever you have an idea that you want to talk about, I love talking. As you can
That
tell.
sounds great. We'll have you back another time. Thank you
Okay.
again.
You're welcome. Take care and stay healthy, everybody.
Thanks. Same
Thank
to
you.
you. Well, I don't know about you, but after this conversation with Dave, I feel more passionate about being an advocate for our profession. I feel more encouraged about where our profession is going, and I definitely have a better understanding of optimal team practice. I think sometimes we get so in the weeds of what we're doing day to day at work that we forget that we're part of this bigger profession, that we're part of this collaboration with other PAs and other healthcare professionals, and we fail to see how these policy changes can affect us on an everyday basis. So, thank you for tuning in to another episode of The PA is In. If this helped you in any way, do me a favor and share it with a friend, leave a 5-star rating and a written review. Those reviews are vital to a show this size, and they help other PAs like you to find the show. All right, that's all for today. This PA is out.